so much for joining us today, Dr. Hannam.
Thank you, Vidya.
Today, as many of you may know, September is Polycystic Ovarian Syndrome, or PCOS, Awareness Month. And Dr. Hannam would like to chat with us about how to get pregnant when you have PCOS and what the challenges are with that, how to diagnose it, and how to have a successful outcome, or how you can try to have a successful outcome with this condition. So Dr. Hannam, do you want to just kind of take it away and maybe tell everyone what PCOS is and how to identify whether or not you have it?
Thanks, Vijay. I'd like to, and I hope I can be of help today. Vijay, you've spent a lot of time with Fertility Matters, and before this started, we were talking about PCOS and how common it is, how frequently it's a part of the fertility story. Do you find that the fertility community is asking you guys a lot of questions about PCOS? Does it come up often for you guys?
It's a very frequent question that we see from the fertility community. So we know it's very widespread, and there's a lot of confusion and potentially misinformation out there about it.
You know, one of the big challenges with PCOS is nobody can quite agree on what the diagnosis is. For a helpful primer, if anyone wants to read up about this afterwards, New York Times put together a nice little piece not that long ago. You can just Google NY Times PCOS and it'll pop up. It was not badly written at all, and really just covers the spectrum of what it is that people are worried about when they worry about PCOS. PCOS, Polycystic Ovarian Syndrome. It's an old name from medicine before it was politically correct, and it is a little bit of an odd name too, because it implies the person has a lot of cysts. Cysts is a complicated term for women. If every time that a woman of fertile age does an ultrasound, they'll find a cyst on the ovary. A cyst is what one expects when you're ovulating. Eggs that are maturing grow within a cyst. We call it a follicle. Then the follicle bursts. It's around for a couple of weeks afterwards, busy making estrogen and progesterone. When that follicle finally, when that cyst finally disappears, a woman will have her menses. So it's always normal to have a cyst, and it's about 2 centimeters in size when the egg's released. That's not what polycystic ovary is. Polycystic ovary is before the eggs even started growing. So it's not 2 centimeters in size, it's 2 millimeters in size. And old ultrasound machines were not that great at detecting it. So the criteria for PCOS is 2 things. One is knowing that you have lots of eggs. So how do you know you have lots of eggs? Well, they set the criteria back in 2004, saying that they can count those little tiny 2 millimeter antral follicles, and you need 12 or more of those. Well, with a modern ultrasound machine, lots of women have 12 or more. It's actually normal to have 12 or more. So routinely, a woman is going to go and get an ultrasound done, and the radiologist report that she has PCO, polycystic ovaries. And by itself, PCO is just normal. All that really means is they can see lots of eggs. Like, it's a good thing. If you get an ultrasound and someone says PCO, by itself, that's great. All it means is probably there's just lots of eggs there. So PCO by itself does not necessarily mean anything at all. PCOS is PCO plus one of 2 other things. For some women, it means high androgen levels. So what they experience is a life of more testosterone than they would like. But for most women, it's that they experience irregular cycles. And that's the essential challenge for achieving pregnancy. I mean, this irregularity can be anywhere from simply not really knowing when your menses is going to happen, which means you don't really know when to have intercourse. None of the apps will work because nothing is scheduled, because you just never know when your period's going to come, all the way to it never comes. There are some women who they don't just have a period every 34 days or every 40 days. They have a period every 70 or every never. And so then it's literally impossible to achieve pregnancy because they cannot time intercourse properly. You know, when people are trying to get pregnant naturally, there's about they say a 25% chance per month, but that's not going to be the case if you're not ovulating. So that's the essential challenge of PCOS is irregular ovulation. I have to look across here because there's some noise back there. Oh, There's cleaning people here at exactly the same time that I'm doing this. I'm so sorry. Let me know that if it gets really noisy, I'll try to make a phone call and make sure that's quieter in the background.
Okay, I can't hear them, so they're
Okay, great.
extremely
Maybe
your
I'm a little,
stealth cleaners.
maybe I'm a bit sensitive.
But let me know if you need to pause for a minute. I think what you're saying, like I have PCOS, and like I guess the lived experience for me was that, you know, my period would come every 25 to 60 days. And when we were trying to get pregnant without assistance, it was basically impossible to know when we needed to try.
Right.
And it was like lots of hardships on a relationship, on you physically, just never knowing when you should even try. Another
Yeah.
challenge, as you mentioned, was also like ovulation kits didn't work for us. We used like electronic ones and like the ones that you buy that are just like a pregnancy stick only for ovulation. None of them were able to detect. And I don't know if it was just outside of the window or if it was.
Yeah, how are you meant to know, right? It gets, yeah, it immediately gets super complicated. And so of course you're going to go online to try to work out what's going on, what might be happening. One of the first things people will say, and a lot of family doctors will still say, is that you have to try for a year before you would even begin to do anything. But in the context of PCOS, I'm afraid that's just not good advice. A year was shorthand for 12 cycles. That means 12 well-timed moments of intercourse. Now, we can debate whether or not that's appropriate. The reality is most people get pregnant within 4 well-timed cycles of intercourse. So to make everybody try for another 8 after that is statistically valid. It's emotionally a bit brutal, but none of that works anyways if you're not able to ovulate regularly. So the good news about this is that's something that people can identify for themselves. You know, you know for yourself, if you're not ovulating regularly, and you try to be a little bit obsessive about it, like as you say, a lot of people will of course use an app or use those kits, but those kits routinely don't work that well. They do for women who are ovulating regularly, but with PCOS, people are not ovulating regularly because those hormones are out of sync. And so the very hormones that you measure with those sticks don't work because everything's out of sync. So now the good news is it's a super quick diagnosis to make, because you could go to any ultrasound facility, and as long as they're doing their job and doing the antral follicle counts, counting how many eggs that are there, if it comes back and says PCO or lots of eggs, and you know that you have irregular cycles, then that's the diagnosis.
That's easy.
It is easy.
I wish I had known that.
Yeah. Now, when you have a diagnosis, that doesn't mean that your story is the same as everybody else with PCOS. And so what you'll do is, again, going online, you'll realize that there's a lot of things that are associated with PCOS, but it's rare for all of those things to be associated with you. So I'll give you an example. As soon as you read about PCOS, you'll immediately start reading about weight. So for some women, weight is a concern. Not for everybody. And so like, you know, so here we go, treading immediately into complicated ground. I think we can all agree that medicine has had a complicated relationship with weight, a judgy relationship with weight. And there are increasing guidelines that are really trying to disengage from using, you know, a simple bludgeon of your BMI is too high for this or for that. So it's a very unfortunate overlap with this condition. And it's very unfortunate that a lot of women will go to a clinician, and the first thing they'll be told is, wow, all you have to do is lose some weight. Although actually for some people that might also be true. There are some people who, if they lose about 5% of their weight, they will start to lose their cycle. They will start to notice cycles coming back. So for anyone who's listening to this, I can't tell you if that's true for you personally. I can tell you that advice, so easily said as a clinician, can be awfully hard to hear as an individual, and it may not even reflect your story. There are lots of people of normal weight, however you want to define normal. There are lots of people of normal weight who have PCOS. It hasn't actually, for their situation, has nothing to do with weight. You know, the thing that links all PCOS stories is a really high density of immature eggs in the ovaries. So there are some women, it really doesn't matter what their weight is. They're going to have PCOS because they are going to ovulate irregularly. They have such high density of eggs. So your story might include weight loss, but it certainly does not, that's not true for everybody.
So if you're not at the point yet where you are in a position to have that ultrasound to tell you if you do have a lot of eggs,
Yeah.
or sorry, a lot of cysts, what are the indications that you might consider symptoms of PCOS?
You know, I honestly have to say, like from the get-go, if you know that you have these irregular cycles, it's really worth trying to get that ultrasound. Here's why. There's two super common reasons a person would have irregular cycles. One is going into menopause, actually starting to run out of eggs. Now, based on age, you can judge whether or not that's true for yourself. If you're 24 years old, that's very unlikely. If you're 38 years old, it's not impossible. And if you're 45 years old, it's actually probably the most likely explanation for why cycles are getting irregular. So if you have irregular cycles, it's actually super helpful to get that ultrasound really early in your story so that you know if your story is one of very few eggs, which is relevant, or a whole lot of eggs. Now, if it turns out it's a whole lot of eggs, the first thing you need to know is that the passage of time is not as concerning for you as it might be for others. So what I mean by that is everybody who wants to get pregnant, they want to get pregnant, like they want to get pregnant now. That was the whole goal. But there are other people where if 3 months pass or 6 months pass, it's actually taking away their opportunity perhaps to ever have that pregnancy. Women with polycystic ovary, they do have a lot of eggs. So for them, it's less about panicking around a specific month than trying to overall find the right path for themselves. Like what's the way that they want to negotiate what the next steps are going to be. So I would definitely recommend getting the ultrasound done. At which point, and you can do that with your family doctor. You're welcome to come to a fertility clinic if you want. If that sounds a bit intimidating, you can just go to your family doctor, ask for a transvaginal ultrasound. It's an internal ultrasound. That's the best way to do an antral follicle count. That's the specific study where they're counting how many eggs, and that'll let you know if you have irregular cycles and a high antral follicle count that you actually have PCOS. And then what? All right, well, then if you do, what you might want to do is rule out some other things that are commonly associated with a condition. So I mentioned weight, and I can't tell anyone who's listening if they need to make changes there or not, but some people might want to. Other things that you might want to do. You and your doctor might want to do some blood tests, because here are some things that are pretty commonly associated with polycystic ovary. One is hypothyroidism. So the thyroid's running a little bit low. What an easy treatment that is. You can take thyroid replacement pills and find that cycles start to regulate themselves. Another pretty common association is a tendency towards diabetes. It might be frank diabetes, or it might just be that sort of insulin resistance. And the one way you can tell that is the test is called hemoglobin A1C. It's looking at the sugar that's stuck onto your blood cells. This is not a fasting blood test that you have to do. You can do it anytime, but your hemoglobin A1C should be pretty low unless your sugars are routinely too high, and then it's going to be a high number. So that can let you know if there's other health concerns besides PCOS. Okay, here's the spooky one. Women who don't ovulate regularly, it means that they don't have progesterone regularly. And if you don't have progesterone regularly, what your body is often doing is it's stimulating the lining of your uterus all the time. So a regular cycle is estrogen stimulates, progesterone stabilizes, and then you have a period. But if you never have that stabilization, you might never really have periods very regularly. And over the long term, you might be at an increased risk of endometrial cancer. So one of the things that they'll do when they do the ultrasound is measure the thickness of the lining of the uterus. And if anyone's concerned, they'll do a biopsy test. Biopsy is like, if you haven't had it, I would suggest it's like a really unpleasant pap test. The setup's like a pap test, but then they're going to pass a catheter through the cervix. For most people, that's okay. And then it's into the uterus itself. And for a lot of people, this part's not okay because they're putting negative pressure on the catheter, and it's going to pull some of the lining into the catheter. Lasts about 7 seconds. I'm not selling the test very well, am I? Because it's a lousy test, but it can be.
You don't want to ask me either.
No, I know. Yeah, okay. You've had the test, did you?
I've had the test 6 times.
Right? Okay. So you're well aware. It's not a test that you would ever want to get done, but what are you going to do? Sometimes you need it done. And for women with polycystic ovary, it might be part of the overall check to make sure that your overall health is okay. What we're looking for is endometrial hyperplasia, the beginnings of early cancer. It's definitely treatable. If you're someone who's listening right now who has endometrial hyperplasia and PCOS, please don't hesitate to reach out to me. There's some, we're doing a study with U of T. We've got some treatments available to us that are not widely accessible. But fortunately, most people won't have such concerns, and they'll be in a position to say, okay, overall, my health is good. I may or may not be needing to work on my weight. Definitely interested in getting pregnant. And now what? That's a pretty common position to be in. If that's yours, the most common way we help people is with clomiphene or letrozole. And they both work in a similar way. They fool your body into thinking your ovaries aren't doing anything. So what clomiphene does is it blocks your body from seeing estrogen. If your body doesn't see estrogen, it's going to stimulate your ovaries a little bit more. And maybe that's a good thing, right? You've got all these eggs and they're holding each other back from growing. If you can stimulate the ovaries a little bit more, maybe you'll release an egg. And there's some problems with that, because maybe you'll release an egg, or maybe you'll release 3 eggs or 5 eggs. Clomiphene is, it's a bit spooky for that. You can release a lot of eggs with clomiphene. So the response tends to be all or none. Either the dose wasn't quite enough and you don't get any eggs to release, or you hit a threshold and suddenly there's a bunch. And the fertility doctor will say, oh, I'm super scared here. I don't want you to get triplets. And the patient is like, look, I've been hoping to get pregnant for a year or a year and a half. This has been awful. I'm just gonna try. And so it's people with PCOS that actually are the ones who get into those high order multiple pregnancies that we've all heard about. You would not wish on anybody. They're not super safe. If you are taking clomiphene, I hope you're in a position, at least for the first cycle, so you can see how your body responds, to make sure that you know how many eggs you're releasing. You do have to be careful with clomiphene. Multiple and high order multiple pregnancies are a real risk. Also, it blocks estrogen, so a lot of women just feel lousy on it. It's okay for one cycle, but if you take clomiphene for several cycles in a row, that anti-estrogenic side effect builds up, makes a person feel menopausal, hot flashes, vaginal dryness, depression. Like anyone needs that on top of fertility and any other issues associated with PCOS. Pretty common though. So if you're on if you've been on clomiphene for a long time, my sincere ask is that you give yourself a break, at least for 2 months. Let it wash out of your system so that you can get back to being who you are, and then you can decide where you want to go from there. If clomiphene's going to work, honestly, it's probably going to work in the first or second cycle. After that, you're increasingly looking at the side effect profile and less and less likely to be getting pregnant. That estrogen blocking, one of the places it blocks is the lining of the uterus. So after a while, you even have to wonder how good the implantation is going to be. Okay, so the other medication is letrozole. Letrozole's easy to take. It's been used hasn't been used for as many years. Safety profile looks to be excellent, tend to only release 1 or 2 eggs. It stops the estrogen from even being built. So it sounds like you're going to get the same side effects, and you can, but it just isn't in your system for as long. So if you take letrozole, that side effect profile I discussed, it's probably not going to be as apparent. And you can take letrozole for up to 6 cycles, confident that you're probably not going to get into a significant amount of side effects, and you might start ovulating regularly. Because that's our best case scenario with PCOS, is when we can help someone ovulate regularly, maybe with clomiphene, more likely with letrozole, maybe tweaking their thyroid with thyroid pills, maybe helping their sugar levels with metformin. If we can just do that, they can get pregnant naturally, having intercourse. That's the best. That's the least interventional way we can help someone. PCOS, you don't really have to do and treat on inseminations. You can. Sometimes people want to, because by the time they're ovulating, they're like, they can't deal with having intercourse as the method of procreation. They're at that point, they're like, maybe we'll have intercourse for ourselves sometimes, but right now I just need to get pregnant. So that's a good reason. Some guys have situational erectile dysfunction because having intercourse has gotten so weird at this point. But just as a medical procedure, if his sperm counts are good and you don't have concerns with intercourse and anatomy is reassuring, you should be able to get pregnant with intercourse just as well as you could with IUI. It's more about just knowing when you're ovulating and making sure you have the chance for getting pregnant then.
Great.
Look at me, blah, I'm talking the whole
No,
time.
it's all good. It's all good
Okay.
information. Everyone wants to know. Just to interrupt for 1 second, to anyone watching on Facebook, please just put your questions into the comment section on Facebook, on the live feed. You know what I'm talking about. Okay. I'm getting a lot of comments. Sorry, I'm trying to like weed through the comments.
Yeah, okay, no, that's good. That's good. Yeah. If it was a normal conversation, I would be asking questions of the other person right now too. I want to hear what it is that people need to hear.
Okay, we've got a question here. Could you talk about other meds or supplements to help with insulin resistance besides metformin, or when metformin might be a good option?
So my strong suggestion, when if your PCOS story includes insulin resistance, my strong recommendation is to integrate naturopathy into the process, as well as seeing a fertility doctor, an OB-GYN, or family doctor. Why naturopathy? Because strong naturopaths have a really good basis for understanding how diet and lifestyle might really make a difference to their care. So we work with A to Z Wellness. I think they're terrific. But there's across the country, there's really strong naturopaths in every city, and they can be in a real position to help people. When is metformin necessary? A lot of debate about that. If your hemoglobin A1C is normal, I think we can make a strong argument that it's not necessary at all. But you know, in the literature, some people have wondered if it helps people even with normal sugar levels. That's debatable. But some doctors, that's something that they would like to try. And if you feel that your cycles are not regular, you'd like to try everything you possibly can, people will routinely start adding in metformin. They're 500 milligram tablets. You might take 500 milligrams once a day. And if you're feeling okay, twice a day. If you're still feeling okay, up to 3 times a day. People start to get gastrointestinal side effects after that. What do I recommend after that? Well, you know, I used to recommend a number of different supplements, but I'll be honest, I've really started to back off. The longer I've been doing this, the more I understand that everybody's response to diet is different, and that there are no specific dietary supplements in my mind that work for everybody all the time. So what I started to do is pivot towards supplements that might be associated with increasing egg quality. So for me, the primary one there is coenzyme Q10. Now, like so much in fertility, lots of debate about the specific dosing and requirements for that. Coenzyme Q10 was validated with mice, and they were never able to validate it for women because people just started using it. So no one's ever actually quite agreed to what the appropriate baseline dose is. It's reasonable to have 200 milligrams. Many people will take 400 milligrams. 800 milligrams is a high dose, and you think, right, dialed in, I'm doing 800, then I'll do whatever I have to do. Just be careful because coenzyme Q10 does give you a bit more energy. So if you take it at night, it might be hard to sleep. If you take it in the morning, it can be hard gastrointestinally, it can be a bit uncomfortable. You should not have to tolerate any side effects at all from coenzyme Q10. I would suggest that 400 milligrams is the right dose for most people.
Great. Question here, why doesn't PCOS and the associated symptoms go away after menopause?
Wow, so actually a lot of them do. So one of the solutions for PCOS is the passage of time. For most women, they will start to have more regular cycles in their late 30s because that very high ovarian reserve starts to become a more normal ovarian reserve. So there's a real chance for a woman in her 20s or low 30s that if she hopes to have more children in the future, she may well be able to achieve pregnancy without any intervention at all, just because her ovarian count starts to drop down and she starts to enjoy the same regular cycles as everybody else. By the time women are in their mid 40s, almost everybody has a fairly low antral follicle count at that point. Still, women with PCOS might find that the average age of menopause at 52 comes and goes and they're still ovulating. So there are women who will ovulate until they're 54 and 56 and 60. That is all a hallmark of PCOS. By the time a woman hits menopause, she has run out of eggs and she no longer has PCOS. So remember the two parts of it being irregular or absent cycles and a high ovarian reserve, but she no longer has that high ovarian reserve. Sorry.
It's a very active comment board here today. So that's about when PCOS ends. When does it begin? Like, did we do anything to get PCOS, or do we just luck out that way?
Right. So, well, there is some family history to this. You know, you can look to people, your first degree relatives, a sister or sisters, your mom. You'll often find that this is in families. A question you can ask of your mother is if her menopause was later than age 52, that's a sign that there's a high ovarian reserve that's in this family. If she tended to have irregular cycles throughout her 20s. When you look to your own personal story, most women have regular cycles when the whole process starts up. So age 9 or 11 or 13, whenever your menses started, it's normal for it to be irregular at the beginning. But by the time women are deeper into their teenage years, most women will start to enjoy some more regular cycles. And if you didn't, that's in retrospect, or if you know a young woman who has irregular cycles well into her menstrual years, it's actually worth doing that ultrasound and getting that personal diagnosis. Nobody did that to themselves. That's just a person just happens to have an awful lot of eggs. And what are you meant to do under those circumstances? Well, if you're not trying to get pregnant, a lot of doctors will encourage women to consider the birth control pill. Again, we do want to have some progesterone around sometimes. That risk of endometrial hyperplasia does worry us over the long term. But another perfectly reasonable solution would be an intrauterine device. They often have a little bit of progesterone. And then if that's unacceptable, some women would rather just take progesterone tablets only, perhaps every 3 months. But you heard me give 3 different solutions, all of which do ask for some hormone manipulation because their own body isn't giving them progesterone. So we're trying to help give progesterone back. So what could that person have done differently? Nothing. They could not have done anything different. That's how that person was born. As I say, if this diagnosis applies to you, it's worth double checking that weight or thyroid or insulin resistance isn't part of your story. But for most women, it's just inherent to themselves. For better or for worse, they were given the genetics of having a lot of eggs.
Excellent. So you're saying I got it from my mama.
Take it back to mom. It's a burn, isn't it? Because, you know, if a guy has really high sperm counts, he's like, yay, clever me. But if a woman has extremely high ovarian reserve, big picture, that's a good thing, but it can make for a very stressful getting pregnant part. And what a drag. What a drag to have to start taking clomiphene and letrozole and the other medications that we use and all their side effects. It's really not the way anyone would have wanted to have to access pregnancy. But there it is. That's how it is for people with PCOS.
So there's a question here. I know you mentioned IUI is usually 6. Sorry, that's my dog Beaumont. Yeah. I know you mentioned IUIs are usually successful with PCOS once we can get ovulation going. When do you recommend moving into IVF if IUI hasn't worked after several rounds?
Great question. So in our clinic, we really do like to see people achieve pregnancy within 4 ovulatory cycles. It's not a magic number. It's just not everybody's going to get pregnant through having intercourse or IUI alone. And the good news is for people who will get pregnant, 70% of the time, it's going to be within those first 4 cycles. All right, so what if you've already done 4 cycles, whether it's through intercourse or IUI or a combination, it hasn't worked. In our clinic, we will actually continue with people to a 5th and a 6th cycle, unfortunately, the pregnancy rates are not as high at that point. Uh, uh, we just released our internal data to ourselves again for women with PCOS. The pregnancy rate per cycle is between 15 and 18%. It's not super high, but the cumulative pregnancy over 4 cycles or 6 cycles ends up being about 50%. So when the fertility clinic tells you that you're great prognosis, you are great prognosis if you consider 50% great. It's great when it works, but I discourage people from doing more than 6 cycles for a couple of reasons. One is it should have worked by then statistically. It might work on the 7th, but you're increasingly getting to the other reality of this. It's super stressful to go through multiple cycles, and to go through 6 cycles is probably going to take a lot more than just 6 months, right? With for various reasons, various complications to do with your life or the clinic, or a missed phone call, or someone's traveling, or reasonably someone would just like to take a break from hormones for a cycle. 6 cycles can definitely take 9 or 12 months. And though you haven't reduced your chances for having a baby, remember, you're the person who has a lot of eggs, you have definitely increased the stress level. I know IVF's not for everybody. I recognize it's expensive, but it certainly controls timelines. So my recommendation for people, taking finances aside when I make this statement, at 4 cycles, I would start to have conversations at home. And at 6 cycles, I would very seriously be asking if we should be doing IVF. If not IVF, then at least a second opinion with another clinician to see if that you're still on the right track. You know, second opinions, they're pretty easy to get done these days because everyone's doing virtual medicine. Regardless of where you are in Canada, you should not feel locked into your local practitioner, at least for a second opinion. Fertility has been very busy since we closed in the spring. I'm not speaking to my clinic, I'm speaking to the community. I've heard of wait lists for various clinics that are extremely long these days. That might be the case for you in your community. You might be finding it difficult to access somebody. Please know that getting someone by Zoom or a telephone call at various clinics around the country, even outside of Canada if you need to, usually consults in and of themselves are not overwhelmingly expensive. You can get an awful lot of information, if you can get the clinical information that you've had to that point. Hear that from a second clinician. Doesn't mean you're committing to care with them. You are not necessarily breaking your relationship with your primary clinic. You're just trying to get information. And if it's been 4 to 6 cycles, I'm suggesting that it's time to look to change in some fashion because the pregnancy rates aren't as high as they should be at that point.
That's a really great point. That's like probably the biggest lesson I learned through my journey is I felt very like tied to my first practitioner and you know, thought that I would be wasting time moving on or asking for anyone else's input. But it turned out that that was the best thing for me. Different doctors have different perspectives and different approaches, and even the fit between you and your RE would be different depending on who you're working with. So
and you might love your fertility doctor, and you might realize after your second opinion, you're like, great, you know what, they said something pretty similar, and I actually really like where I am. I like my team. You know, people do worry about even asking for their records. Are you hurting any feelings? And the answer is actually, and sometimes yes, you are. I would suggest that if a doctor is not happy with you asking for records for a second opinion, that I question the stability of that relationship, because I feel that, well, first of all, I feel that a doctor should be able to handle that. But from your perspective, these are your records. So you should always feel very secure, always having your records, and being open. So, you know, I just needed to learn more, and this is the way I'm learning more. And I'm really happy to stay with you, or I'm going to move to this other person. This is your story. And look, it is hard to get second opinions. Even if the information is almost exactly the same, it'll be presented in a different way. And a lot of fertility doctors are going to try to sell you on themselves. So I know it's hard, but if you've been in this doing the exact same thing for 6 cycles, something has to change. Something has to change. I think.
Great advice. So here's a little bit more of a personal question. I'm not sure if you're able to answer this without more medical background, but 5 failed IUIs. It turns out that my thyroid was high, not my thyroid. This
Understand. Yeah, we're reading the story. Yeah.
IVF stimulation failed and I converted to IUI now with my thyroid under control. Do I have better chances now with my thyroid under control?
Yes. Yeah. Whether that's true for whether you choose to have intercourse or you choose to do IUI or you're choosing to IVF, in all those circumstances, you're going to, if your thyroid feels safer to you now, you should have a better response. Now, thyroid is, we follow TSH levels, and the fertility community likes to see TSH level of less than 2.5, but you need to know we're being super obsessive when we say that. Truly, a TSH level that is between 0.4 and 4, it's probably all fine. Now, as you start to drop into true hyperthyroidism or excessive hypothyroidism, it will make a difference. So you're right. I can't tell you in your particular case, the person who's asking the question, how much it'll make a difference for them. But hyperthyroidism can make a real difference to all aspects of someone's care. And if it took some real work to get that back in place, it's reasonable to reassess your fertility story and wonder if things that didn't work before could work again. I'd be careful with yourself emotionally. I would be worried for you if you were going back to IUI. I get it if you have to financially, but we already talked about the success rates with IUI not being super high. With IVF, they're meant to be actually really high. You mentioned failed IVF. My hope for you was that you did get a lot of eggs. If you have PCOS, you should, with IVF, have a lot of high quality eggs. And I'll be honest, it's hard. The first time we run a cycle for someone with PCOS, we're just doing our best to get the right dosing, and we don't always get it right. And so a person can get way too many eggs, that's ovarian hyperstimulation syndrome, or not enough. Sometimes we're being so safe, trying to keep everything so super safe with PCOS patients that we over safety it, and the estrogen level's not that great. You get an okay number of eggs with not great estrogen levels, and the whole outcome isn't what it could have been. If you have failed IVF as a PCOS patient, it's well worth asking the question if something could have been done differently with the stimulation to make it better for you. So my advice would be to seriously reconsider doing IVF again. I'm sorry, I'm not accounting for money when I say that, and to if necessary, get a second opinion around all that story, because it's a surprise to me that you would have run a first IVF when you're hyperthyroid. So I would like to have you have a second opinion from someone to make sure that that you are in control of your story before you try that again, because it's IVF's a big commitment.
Thanks. Let's talk about IVF with PCOS. You just kind of talked on it, that the chances are that you will get a lot of eggs. When we talk about a lot of eggs, how many eggs are we talking here?
Okay, so IVF. The best case scenario for IVF is you get 15 eggs. Actually, the range is 15 to 25 eggs. I know that sounds like a lot, but I'm going to give you some averages that come out of our clinic right now. On average, 4 eggs makes a blastocyst. Not all blastocysts are genetically balanced. And even when they are, they don't always stick. So here's a super rough number. Half the blastocysts can turn into a baby, okay? So if you get 16 eggs, that's 4 blastocysts, that's 2 babies. Is it really 2 babies? The math says it's 2 babies. Things don't always go the way they should in a fertility clinic. So you want 16 eggs because then you're really meant to have a baby. So that's why the goal for IVF cycles is to get between 15 and 25 eggs. Of course, we can have great cycles when there's only 8 eggs or 6 or other numbers, but that's a goal. So how many eggs are you going to get as a patient with PCOS? Well, the best predictor for that is your AMH. And there's 2 different units for that, but I'm going to describe AMH in picomoles per liter. Your AMH in picomoles per liter is about how many eggs you're going to get if you do IVF well. So if you have an AMH of 40, you're going to get 40 eggs. That's a crazy number. It does happen to us sometimes. I don't ever want to get 40 eggs from somebody. I will sometimes, because some people are, as I say, they're super sensitive to the medications, more than I'd intended. But that means if your AMH is 40, you and your doctor are going to want to give you less than maximum doses of fertility medications. A relatively low dose, for example, would be 125 units. And that's a dose I'll give to somebody who has an AMH of 35 or 40 or 60, because I don't want to get 35 or 60 eggs. I will. It'll happen to us sometimes, but we do worry about that. The human body is probably not meant to make that many at once. So outside of hyperstimulation syndrome, which is a worry, and outside of the physical discomfort, which is horrendous, you're also probably not getting the best quality eggs you can. You're probably just not, your body's just not able to support that many eggs growing at the same time. So as a patient who wants to, as a PCOS patient who wants to do IVF, because maybe her fallopian tubes are blocked, or maybe her partner's sperm's not that great, or maybe she's super not down with trying for 6 cycles, which can take a year at 15 or 20% per cycle, or whatever your personal odds are, you might be like, I'm just not doing any of that. I'm gonna do IVF, where what I just heard is I'm guaranteed to have a baby. Because many people, the math would say they are. What you would wanna do first, you and your doctor, you're gonna wanna get an AMH test done. It's a simple blood test. Most places in Canada, it's not covered by provincial insurance, but the cost will range between $50 and $175 depending on the lab. And that's going to tell you how many eggs you guys can expect. And that is by far the best predictor for how successful your IVF is going to be. Oh my God, I'm talking so much. It's awful. Vidya, just interrupt me if you're like, okay, pull back.
No, you're fine.
I like the subject. It's interesting. So there we go. Yeah.
It's nice hearing from someone that knows what they're talking about, as opposed to like the commenters on like the depths of the internet. So
well, we all go there, don't we? When we're obsessed, we all go to the corners of the internet that tells us what our heart is most worried about. So it's all out there for sure.
So question, we're talking lots and lots of eggs, right? Yeah. What's the relationship between egg quality and PCOS? Does PCOS have a negative impact on egg quality, or are they kind of independent of each other?
People have worried about that. It really, I would suggest to you, in almost all cases, there's no connection between PCOS and egg quality, but I'm going to have 2 caveats. First of all, if you find yourself doing IVF, either because of passage of time, or you tried things like clomiphene letrozole and they weren't working for you, you had to do IVF. If you get an awful lot of eggs, or conversely, if the doctors are struggling to get the balance right with the medications, you can get poor quality eggs. All right, it's a technical issue. It's a challenge that we will have with you in generating. Like you should be able to generate great quality eggs. We're just struggling with the medication balance to get that right. And I'm not minimizing that. That's really difficult for people to be told, I'm sorry, it wasn't perfect, let's do it again. But that is the reality. So there you go. Great eggs, but we struggle with IVF to help them mature to be great. Here's another reason. I will come back to weight. A higher BMI really does make a difference when you're taking IVF medications. Here's why. You're taking IVF medications subcutaneously, and ideally they just go straight to your ovary, but they don't. They go everywhere. So if you have a lot of fat cells, the medication is going to tend to go to the fat cells. We can do our best to increase the doses to get it right, but it's really difficult. It looks like the egg quality that comes from women where a diet or weight is a serious issue, they do look like they're compromised. There's some really good data out there that suggests that if women can move to a low glycemic index diet for the 3 weeks prior to IVF, even if they don't lose any weight, they're going to get better quality eggs as a result. So I don't think PCOS by itself leads to poor quality eggs, but I would suggest that if your clinic is struggling, or if other aspects of your health have not been optimized, from weight to thyroid to glucose, you can run into egg quality problems. If everything's been optimized, you and your clinic have found a protocol that works for you, we get great quality eggs.
Great. I want to be conscious of time, but you touched on 2 things that, for the audience, full disclosure, Dr. Hannam was my doctor at the end of my journey. So there's 2 things that you and I talked about that I feel like isn't well known. So can you talk about estrogen levels during an IVF cycle and how that is an indicator of egg quality.
Sure. Do you want to refine that question at all, or like was there anything in specific that you want? You brought up our relationship, Vidya, which was very brave. I'm always impressed when people in a public space are able to talk about fertility. It's such a private thing. It's not anything that everybody needs to do, but it makes such a difference for others. So thank you for all the work that you do in that. Can you tell me what it is about estrogen levels that you learned or want other people to know about?
Okay, I'm not gonna get the medicine right here.
I don't mind.
So.
I don't mind. I'm just trying to, yeah. I'm not trying to put you on the spot. I just want to know what you feel was helpful to you.
So, oh man, it was a while ago, folks. So sorry, but there was something around like the estrogen level needing to be X amount per egg to indicate good quality.
Great, I can definitely speak to that. Thank you. So, in a natural cycle, a woman's, and these are all Canadian units that I'm talking about. Across Canada, it'll all be the same. In a natural cycle, a woman's estrogen level, she's going to grow, she's going to have her little antral follicles. And if she doesn't have PCOS, if she's ovulating regularly, her estrogen will rise as the follicle develops, and it'll peak at about 1,000. And the estrogen comes from the cells that support the egg. So if you want to have lots of supportive cells, making the best possible eggs. And if that's the case, you'll have an estrogen level about 1,000. So if you have 5 follicles in IVF and you're hoping for 5 eggs, you kind of want an estrogen of about 5,000. That means if you're hoping for 15 to 25 eggs, you're looking for an estrogen level of 15,000 to 25,000. And I'm mentioning all that because it's one of the things that we'll look when we're doing a second opinion for people. How well did their first stimulation go? As I said, it's really tricky for us to get the balance right of stimulating medications and the other ones that stop someone from ovulating. Women with polycystic ovary, they really do tend to have this all or none response. You're giving someone too high dose and oh my gosh, suddenly you pull it back and maybe you over pulled it back. And at the end of it all, the patient's left wondering, well, was that good or wasn't it good? And what you're looking for is some match between the number of eggs that you retrieved and your estrogen levels. If you have polycystic ovary syndrome, you've been told you have a lot of eggs. So you would really hope that at IVF, your estrogen at retrieval is going to be somewhere between 10 and 25,000. If it's less than 10,000, it may be that your clinic accidentally understimulated you in an effort to keep you really safe. I said maybe, that's not a necessity. I don't know. I'd have to see your own individual case to have an opinion for any one person. But it's really, that's one way that you know an estrogen level of about 1,000 per egg. That's a way that you know that your body was able to support the eggs that were growing for you. Did that answer the question, Vidya?
That did. I feel like I learned that way too late in my journey. And it was like,
I see that was something
yeah. The other thing that I found really helpful from working with you was around exercise. You talked a little bit about fat cells and how they can affect how someone would process medicine.
Yeah.
And I know that, women everywhere trying to get pregnant are very concerned about their activity levels, and they get a lot of mixed information about working out, lifting weights, being very active. Yeah. What are your thoughts on that?
Sure. Okay. So I feel confident in this space because I can tell you that nobody knows anything. Okay. So this is my opinion as someone who's very interested in athletics, and like many of us, I go great guns and then I seem to quit again, and then I'm like, no, I'm back in again. And here's what I think about this. There's a lot of guilt for people who are looking to maintain a lifestyle and try to get pregnant at the same time. It's very confusing if you're allowed to have a glass of wine or not, if you're allowed to go to the gym or not. If you have to go to the gym, I'll update this conversation now around COVID. Or what exactly are you meant to do? Are you allowed to go running? You know, you read that running is really bad for fertility. How does all this fit together? So here's an answer. Exercise is so important, guys. It makes such a difference to so many aspects of our health. Now, I am not trying to add in yet another you should. But having said that, there's a strong argument for aerobic exercise that gets your heart rate to around 140 beats per minute. So most of us, when we do aerobic exercise, we're like, okay, fine, I'm here. I don't want to be here, but I'm here, so I'm going to beat myself down. So we do 20 minutes or 40 minutes or 90 minutes of really as hard as we can go. And you can do that. If you do that, you'll find your heart rate's probably between 150 and 180. It's totally fine. But you're burning sugar the whole time when you do that. So you'll blow up at night. If your muscles are strong enough, you'll keep going until about 90 minutes and then you blow up. So what's actually far more helpful is aerobic exercise that brings your heartbeat up to no more than 140 beats per minute. When you are between 120 and 140, it's fat burning. So to the degree that you're interested in losing weight, I strongly recommend just getting up to that 140 beats per minute. It's really amazing. Over 12 weeks, you'll notice absolutely nothing. And then actually you really do most people will really start to notice a difference in weight. But more importantly, far before weight change are real metabolic changes that we can see affect people. If you also enjoy weights, go for it. Do that. You know, building up muscle mass is not a problem if that's what you're interested in doing. Stronger legs, stronger arms, strong core. What's wrong with that? Muscle is going to help process higher glucose levels, and it's definitely associated with overall great health. But I would not limit yourself to that. So if your deal is you're into, you know, doing the absolute those super short workouts, they're exciting, like the 7-minute workout, all those things, they're great. I don't want to minimize it, but they are anaerobic. So at best, you're I'm doing muscle work. I strongly recommend fast walking. Truly, if you do fast walking, hit some hills sometimes, you'll see your heart rate will go to 140. Would you rather run? Do it, but do it for like 30 minutes, like commit. And here I am saying 30 minutes. Do it for longer if you can, but 30, do for 30, like go there. Because 30 minutes at 140 beats per minute, after a few weeks, you can totally do that. And if you do that 3 times a week, it will make a huge, huge difference to all aspects of your health. At a minimum, let's hope that makes you feel happier. At best, it's something that might help with your fertility.
Great.
That's what I think about exercise. I think it's awesome. You know, you can do the thing about things like heart rate 140 beats per minute is that's brisk walk. Like you can definitely do that after your IUI. You know, it is not incompatible with all the fertility treatments that you're going through, and all the hormones that people are being asked to take. It really threatens all kinds of aspects of body image. So if you enjoy exercise, I hope you take the opportunity to allow yourself to do it. And if you don't like it, I hope you can find a way to walk anyways, because it makes a big difference.
That's just to close out that conversation about exercise. When is it safe to exercise and when is it not safe to exercise during treatments?
Great question. So when you are trying clomiphene or letrozole or intrauterine insemination, the answer is you can exercise all through that. When we do an IUI, there's no specific instructions we give the person that day because the sperm went up that day, but it's going to take a whole week for the embryo to float down an implant. That's why the activity level or whatever that person chooses to do that day is not all that relevant to whether they'll get pregnant. Okay, it's different with IVF. Women with polycystic ovary syndrome, we talked about just how many eggs can grow. So when you're growing a lot of eggs during an IVF stimulation, those ovaries swell up a lot. Maybe for the first 5 days of stimulation, it's fine. For the last 5 days, not so fine to be super active. Your ovaries will be really large. But here's the good news about that. You can let your own body be your guide there. If you're really uncomfortable because you have swollen ovaries, don't exercise. You won't want to anyways, and don't. It's just not the time to be working through the pain. That's really swollen ovaries. I'll scare you now. At most, if you're too active, they can even twist on themselves. I've never seen that happen, but it can in theory. So if you're in the midst of an IVF cycle and for the days afterwards, if you're still uncomfortable, don't exercise those days. But I'm talking about a very small window. That was about 10 days. All the time before that, all the time after that, absolutely fine. If you are now doing embryo transfers, you now have an embryo inside of you. Should you be exercising then? Well, I'm gonna flip it around and say this. Yeah, you can exercise, and yes, you can have intercourse. And yes, you could probably have a glass of wine with dinner, but really, I mean, should you? You know, the thing about putting an embryo, by the time you're doing an embryo transfer, is at that moment, you've put an awful lot into that, and you've got 9 days to wait. Here's my concern with any of what I just said. There's so much room for for guilt and self-blame if you don't get pregnant. So my suggestion would be this. If you've just done an embryo transfer, and you're considering an activity, whatever it is, ask yourself, if you don't get pregnant, are you going to feel guilty about it afterwards? And if that's you, if you would, then just don't do it. Just don't have intercourse. Who cares? It's only 9 days. And then you're pregnant, I hope. And once you're pregnant, of course, people who are pregnant have intercourse. Of course, people who are pregnant find that they can exercise at 140 beats per minute. You know, but maybe just so Vidya, you asked, are there any restrictions? I would say, maybe be cautious during those 9 days, but really just because you're trying to take care of yourself.
Yeah. I feel like you're going to get all of your female patients asking you to write doctor's notes to get them out of intercourse.
I think nobody should ever have intercourse if they don't want to have intercourse. It seems like a sort of a basic human right.
That's pretty basic. Like, yeah.
You know, it's like, I think we should just accept that as, yeah. But,
okay. Any parting words having to do not with doctor's notes, but with PCOS?
Yeah. You're going to have a lot of mixed messages. The clinicians you meet are going to keep telling you, great news, you've got lots of eggs, everything's going to be okay. And your lived experience is not going to be that. It takes a long time. Whether you're choosing to do IVF and you and your partner negotiate between yourselves and with each other, whether you want to commit to everything about IVF, the expense, all of it, or whether you decide to take medications and hope that over 4, 8, 12 months, 3 to 6 cycles that you're going to get pregnant. It's all really very stressful. And those things are both true at the same time. You can be great prognosis and both be terribly worried about whether it's going to ever happen for you. I hope that you're taking care of yourself as an individual. Hope you're taking care of yourself in the context of your relationship, that you're still able to take care of each other. It's not wrong to go for counseling. It's not wrong to be asking for help. It's a very isolating experience. Everyone's PCOS story is different. So I hope you are keeping a great platform of support around you. I'm really happy for everyone who chose to join today. I don't know if I was able to be helpful, but that you're doing your best to look for information and reach out and look for community. So thanks for joining us today. And Viju, thank you for hosting this and for Fertility Matters putting this together. It's a big deal that you guys do this.
Thank you so much for joining us, Dr. Hannam. And thanks to everyone who's able to watch today or who's watching afterwards. As you know, Fertility Matters Canada is a not-for-profit organization. And if you're in a position to do so and you'd like to do so, please consider giving a donation to Fertility Matters via the donation link on our Facebook page. So thank you so much. We'll be back again. I believe we're back again on Thursday with information on surrogacy law. So hopefully we'll see you there, and have a great week. Thanks, Dr. Hannam.
Thanks, everyone. Thank you, Vidya.
Bye.
Bye.